3, 2, and 1.
Hi, everybody. This is, it's Tuesday, February, I have to look at my calendar, 8th. And this is Senate Government Operations. And today we're looking at S-158, which is a bill that would allow optometrists to practice within their scope of training. It's an expansion. It's not, I guess it's an expansion of the scope, but it's an expansion within what we have heard from some is the training that they receive. So with that, I think I'm going to, we kind of ended the last session. Now, because some of you aren't used to being with us, I think what we'll do is the committee will introduce ourselves and then we'll jump into it. So I'm Jeanette White from Windham County.
I'm Anthony Polina from Washington County.
Brian Collimore representing the Rutland County District.
Allison Clarkson, Windsor County District.
Aisha Ram Hinsdale, Chittenden County.
So with that, we welcome everybody who's here. And when we ended last time, we kind of abruptly cut off hearing from Lauren because we ran out of time. So I think that what we'll do is, Lauren, if you want to talk to us, and then we'll jump to the other witnesses.
Sure. Good afternoon. Thank you for having me. For the record, my name is Lauren Hibbert. I'm Director of the Office of Professional Regulation, and it's completely fine that you ran out of time and cut me off. It was a good conversation, and there are some points that I wanted to respond to from the last hearing. Specifically, I wanted to respond about the report, the Act 30 report. We were asked to look at the scope of expansion of scope of practice for optometrists, and specifically, we were asked to, I'm reading here for a second, to evaluate the safety and public health needs of enlarging the scope of practice for optometrists to include advanced procedures. And we were directed to consider approaches to advanced procedures in jurisdictions outside of Vermont, patient need for access to additional practitioners, effects on patient access to care, effects on patient safety, costs to the healthcare system, and the existing education and training for optometrists, including the degree to which it addresses the training and education in advanced procedures. And finally, Act 30 directed our office to inquire into the specific clinical training of both optometrists and ophthalmologists for specific procedures. So we undertook this task. We conducted extensive outreach to associations, other states, insurers, providers, and the public. We conducted multiple hearings. We met with all stakeholders on multiple occasions and communicated by email and phone with stakeholders as well. We gathered public comments. We sought information regarding curriculum and courses for optometry schools on multiple occasions through national and local organizations. Unfortunately, we did not receive any documentation until after the report was submitted specific to our request, which was we did not want an affidavit of what was being taught in the school. We wanted the actual curriculum, the actual course syllabi, and we wanted to know exactly what was being taught in the schools. We understood that to be the mandate of Act 30, and we really took our role very seriously to consider the scope expansion and whether it was appropriate. And I heard Senator Ram at the last hearing, Ram Hinsdale, I'm sorry, discussing, who is able to help us in assessing scope expansion. And OPR has played that role for the legislature. This committee helped establish that role more firmly in Chapter 57. OPR takes that responsibility very seriously. We have done scope expansions on multiple professions in with multiple different outcomes. And the way that we do that is we look at all the evidence, we look at what we can gather, we hear all the statements, and we try to make rational decisions based on what we can see and hear from the stakeholders, and in this case, from the schools. So we, in addition to those stakeholder engagements and the documentation sought from the schools, we also reached out to the American Optometric Association, the American Association of Ophthalmologists, the legislative reports that were current at that time that were publicly available. That was the one in Washington, New Mexico, Nevada, and some other states. We looked at the National Practitioner Data Bank reports. That's the data bank that holds malpractice suits. And we looked at state board conduct decisions and complaints, and we reached out to the other boards. We wrote our final report. We filed it in January of 2020. Of course, a lot of discussion about that report was shortchanged due to the pandemic. And we stand by our report that we wrote. We've heard a lot in these hearings that the schools are teaching certain elements or certain advanced procedures. But at the time that we wrote our report, we really could not find that to be true based on the information that we had. We couldn't fairly evaluate the existing education and training for optometrists, including to what degree it addressed training in advanced procedures, which was the specific question the legislature asked us to answer. We also couldn't determine what was the specific clinical training. So it's not just didactic training, it's clinical training. We could not determine that. And that was why we opposed expansion of scope of practice. So we stand by our report in 2020. We really haven't done any further assessments on the topic since 2020. We did receive, after the report was filed, we did receive the information we had requested in the late summer, early fall. And we did review that a little bit, but I have to say that we have been, really haven't done a thorough review. We haven't been asked to do a thorough review. And when that first came in, we were pretty immediately turned to responding to the pandemic. So we have seen that some schools are teaching some advanced procedures, but we really don't know the clinical training or the exact curriculum, and we haven't done that analysis since we received that material. That said, the current bill, we could implement the endorsement if we were asked to by the General Assembly. I do think this is ultimately a policy decision. The office has written the report and stands by the report, but we could implement the endorsement as it's written in this draft legislation. The variations between schools do create some challenge, and that's why we support a third-party accreditor being responsible for providing the qualifications so that we know, without having to look into school by school specific applicants' syllabi. That would be a significant labor-intensive burden for our office. We really want to avoid that at all costs. So we really just ask, if we do implement the endorsement, that the qualifications are crystal clear, or as clear as can be, so that office staff can determine that within the application. We're open to relying on the advanced procedures examination that's offered by the National Board of Examiners in Optometry. The first time that the lasers and surgical procedures examination was offered was in 2019. So when we were writing our report in 2020, it did not seem like a ripe exam to base qualifications off of. But if the legislature wanted to include that exam, we would be open to that as well. And I'm happy to answer any questions that the committee.
I just have one, when you, well, actually two, you rely in many professions on third-party accreditors. So
We
that
do.
isn't unusual.
It is not.
Okay,
Almost every profession we do.
okay. And the second question I have is, and this might not be for you, but my understanding, or the way the bill was originally written, it outlined things that could be done. In this version, it outlines areas, not specific procedures, but areas that cannot be done. And I just wondered if you had any suggestion about which made more sense, or if a combination of the two, or how that would work.
Thank you for that question. I forgot that whole topic area from our last hearing. So yes, I would prefer a list of allowable procedures versus a list of excludable ones that leave ambiguity. So for instance, if there's a list that says you can do A, B, and C, then it's very clear for our office, for the public, to determine whether you've done X, Y, and Z. And that becomes important for enforcement. I think it also provides clarity to the marketplace to have a specific list of approved procedures. And I think it's a good approach when you are expanding scope of practice to give everybody on both sides, which there are here, some clarity on what is being allowed.
That, as I understand it, is the way we do most, when we do scope of practice, we list the new. So is it specific procedures, or is it areas of procedures? I'm not sure here with this, how this works, but it would be specific procedures.
So I haven't delved into all of the procedures and whether they can be grouped easily, but I think if that was the direction that the committee wanted to go, which is not the way this bill is currently written, I think there are groupings of procedures that could be characterized together, but there are also some that really need to be specifically called out.
Okay,
There should also remain, complete bars on certain procedures.
Okay.
There are procedures that should be completely off.
so it is a combination of the two, listing the can do and listing some of the can't do. Okay, Senator Clarkson?
Yeah, I thought that the three areas were pretty clear in which there are, I don't know how many, but a few, several, like 3 to 10 specific procedures. But I thought that the three areas were the anterior lasers, the benign lesions, and the superficial injections, and that basically all the procedures fell into those three areas of those three areas.
No, go ahead, Lauren.
Yes, Senator
Is that
Clarkson,
the
I think that is generally the case, but what I heard from testimony was there was a lot of procedures that could fall into those three buckets, and some concern about which procedures were specifically being discussed. So I think as I would recommend that you understand what those three buckets are and what the full scope of those three buckets could be, and try and determine whether they need to be a little tighter than those three buckets.
Senator Collmore?
Thank you, Madam Chair. Lauren, thank you very much for this. I think I heard you say that you based your recommendation mostly on the lack of information that you had received at that point from the schools regarding training. Was that the only reason that your recommendation was the way it was?
No, there were other factors involved, but I think it's a fair characterization to say that was the primary factor. We had heard, we were really tasked with patient access and patient need, and we assessed that question as well. And we didn't find that it would significantly increase patient access, so we couldn't find that expanding the scope would make it far easier to get these procedures done. We in fact have quite a few ophthalmologists in the state who do provide these services, but the primary was really, the core was lack of education and lack of clinical training,
Thank you.
which concerned us. The clinical piece is probably the most concerning to the office.
Senator
Thank you.
Paulina?
It's actually a similar question to what you were just talking about. I mean, my biggest concern, I think for all of us, is the education, whether the education is adequate or not. And when I read the earlier report, it seemed like you were saying it was not. I mean, I'm being more blunt than you were in the report, but it was not. Now you say later you received information from various schools, and I'm just wondering what your take is now on the educational preparation.
I don't think I have a take on the educational preparation because I haven't been able to gather information from all of the schools. And I haven't had the resources or really, frankly, the ability to really review that education. So I don't have.
That's right. You
anything.
mentioned that the stuff that came in late, you didn't have time to do because of
Yeah,
COVID
no,
and
I mean,
whatnot.
it's interesting to see the timeline. I mean, the information came in on the 3rd and the 6th of March. And, you know, we received that and then immediately we're working on other things that were far more urgent. So I really did not spend a lot of time or my staff's time on reviewing those late filed documents.
It does seem interesting though that they would come in so late. I think if I were at one of these schools and I saw that there's a potential increase in scope of practice, that I would send in the material that was requested and not wait so long. But anyway, that's neither here nor there. It just
No,
makes me
it was,
wonder.
I mean, it's perplexing and quite frankly frustrating because we had multiple requests and including phone calls with some of these schools asking for the materials and we could not get them.
I'll say, I was going to say, if I was an alum of one of these schools, I would be chomping at the bit, angry at them for not supplying the information in a timely manner because anyway, so I just wait, Dr. Smith. The way we do this is the committee gets questions and then we will go to you. Senator Clarkson, did you have a question?
I'd be happy to go after Dorothy, but I watched your tape while I was in appropriations. These YouTube tapes are so useful to go back, and I was so impressed. Actually, a lot of my education concerns were taken care of by Dr. Castillo's and Dorothy's testimony, which were really helpful for me in looking at this. But I have to say, I've just spoken with a very close friend who's an ophthalmologist, optometrist in New Hampshire, and he says access is a huge issue still, and wait times are huge issues. If you send people to DHMC right now, you're waiting sometimes 6 to 8 months for an examination. He's having to send people down to Brattleboro for stuff. He feels that access actually and cost are still issues for us to look at. And one of the pluses of this expansion is that it provides more access for some of these more minor procedures. So I just wanted to.
Yeah, to respond to that, Senator Clarkson, I think we heard both sides of that. And we couldn't find a data point that was conclusive of whether it would expand access in other states, looking at other states and the impacts on access. So we were trying to be, there's a lot of feelings on both sides. We were trying to be as analytical as possible and trying to find the data. And it was harder to find data on how access had shifted post scope expansion in the other states.
Not sure why he's sending them down to Brattleboro in the Bellows Falls area. They're sending them over to New Hampshire because there's no one here. So anyway, any other questions from the committee for Lauren? So I think, Lauren, are you going to stick around with us?
I will. I'll probably multitask, but I will be here if you need me.
Thank you. Thank you. Okay, so I think the next one on our list is Dr. Hitchmuth. So and you had a question, so it makes sense for us to jump right to you now because you had a comment and you're next on the list.
Yeah, thank you. And nice to see all of you again. I'll reintroduce myself briefly just so that you're assured that you can access me with questions on a variety of fronts. So as I said during the last, hearing, I've been a clinical professor of optometry medicine, and I've also taught nurse practitioners and PAs for about 25 years. I'm a accreditor consultant for the Association for Schools and Colleges of Optometry. I am on the board of trustees at the New England College of Optometry, and I've drafted questions for the National Board of Examiners in Optometry and for the American Board of Optometry. So I hope the committee will trust that I can answer on the fly many, perhaps some of your questions about education, both clinical and didactic. Now, having said that, I would like to thank Lauren Hibbert for her comments today and recognizing that there are some gaps in the reporting on the training. So I think that's a great new place to start. I really appreciate her saying that. I have a letter from ASCO that I know was sent to Lauren, and I'm sorry for addressing you by your first name if that's not appropriate. That is written by a Dr. Hoppy, who I actually worked with for a number of years. And they were not really sure what to make of the inquiry, and I think that's really clear in the letter. And they also expressed that they're happy, and this letter is dated January 31, 2020, to provide any additional information that might be needed or requested. And I think that's still the case. As I said, I'm happy to talk about the curriculum across from the closest school in grand detail, but also in general. I've taught for 4 different optometry schools in the clinic, and also medical students and medical residents. So I would like to say that I have a good handle on what people are learning. I will say and I don't want this to sound the wrong way, it's a little crazy to me. I just like to speak plainly that non-medical people are making, a report about medical procedures and medical training when the full curriculum, both in the classroom and clinically, have not been fully vetted. So I don't know that I answered a question, but I did want to reintroduce, and I'm happy to answer any questions specifically that you may have. I'm here to help.
Thank you. Does anybody have any questions for Dr. Hitchmuth right now? Yes, Senator Clarkson.
Dorothy, it would be great, I think, for you to address Anthony's question about the consistency. I mean, I think I feel more comfortable about the education piece, and but maybe you could address Anthony's question earlier about those either gaps in training or the inconsistency between schools, and how optometry is moving to a more sort of national consistency and expectation.
So there's been a national consistency for decades. So we have a unifying board called the National Board of Examiners in Optometry. Every single optometrist is required to pass all 3 levels of that board. There's no getting around that. You can't obtain a license in any of the 50 states without that board. That board does include testing in the advanced procedures that have been referred to in the bill in front of you. However, and that has been taught in all 23 schools for a very long time now. And as I testified last time, I was late, for example, I was laser certified in 96. The industry would have loved at that time, as you can imagine, all of ophthalmology and optometry to be firing its lasers, but for their own financial purposes. So very quickly at that time, not quickly, at that time, optometric scope was expanding rapidly, and the courses were set in motion, and we were learning in the clinic and in wet labs how to use these procedures. I mean, I think ophthalmology would probably agree with me that learning this stuff in the classroom is like the bare minimum. You need to know all aspects of how to use the instruments, the lasers, how to, all the things that can go wrong, what are the outcomes in the scientific literature, et cetera, et cetera. But, it's the hands-on that's important. I was doing all of the hands-on in training and doing it myself for several years as part of the VA system, which, by the way, does allow all of these procedures now. So we have the NAT, to answer the question more precisely, we have a national board. Everybody has to take it. Everybody is tested on the same thing. The schools have to teach to that national level. We don't know, for example, in Boston, if someone's going to practice in Massachusetts or Oklahoma. And we have students from all over the country and internationally. So we have to have like these bare minimums, and that includes clinical training. One of the questions that has come up repeatedly is, well, how can you have clinical training down there in Massachusetts when your scope is like only this? Well, we don't keep the students here, or I'm in New Hampshire. We don't keep the students there. We actually send them out to extensive clinical rotations where they get all of the hands-on training as any other intern or resident would get in the procedures required to pass the boards. And it's not just written; they have to be monitored and they have to show competency in the procedure, which is what you do for all invasive procedures in medicine as well. You can't just say, oh, here I am. I promise I can do it. You have to show competency. In fact, when you go to a hospital to get privileges, you have to show competency. You have to show, even if you've been practicing for years, for example, you have to show that you can safely, in the case of ophthalmology, perform a cataract surgery. So yeah, I, for many years, trained these students in a setting right here in Vermont where we're doing those advanced procedures for the last 25 years. 25 years. This is just not new stuff. And it's absolutely required that they get in and do these things. And to be fair, my colleagues might not like me to state it this way, but to be fair, and transparent and honest. Is it possible that there are some people out there now who haven't gone through recent training that would need to go back and do some brush up, some practice? Absolutely. That happens when you get a new instrument in your office. And I think ophthalmology would agree. There's been some turnover. I work for a large instrument company known as Zeiss. They're the number one seller of surgical microscopes in the world, not just here in the US. And anytime they do an upgrade or a software, you have to go back and relearn that. You have to learn not just the mechanical aspects of the new instrumentation or the handpiece and the software, but how that's going to react to the human body, to the human tissue. So yeah, there are going to be some people. There are some implications also in some of the documentations and also in the OPR report that optometrists don't have training like across the board in medical emergencies or human physiology. And when I did my report almost 20 years ago for the Secretary of State in Vermont, I did a very clear side-by-side that showed that the didactic training was nearly identical. The first 4 years to get into optometry school pre-med, it's essentially the same. Medical doctors take the MCAT, dental doctors take the DAT, we take the OAT, you go on for 4 more years, you do your all the same courses. Like it's not acceptable for me not to be able to manage a cardiac arrest in my office. I'm currently, according to the Vermont law, and also advanced procedures at the VA, was required to maintain emergency competency every year. You can't be injecting. I was injecting a potentially deadly IV medication into the arms of veterans. And you can't do that. You just cannot do those kinds of things without the medical training and background. I mean, people pass out in your office from putting an eye drop in their eye. Sadly, I've even had people bang their head and split their faces. I mean, these are not planned for events. But they are the dangers of taking care of the public. We all take it very, very seriously. And that background training is there. So anyway, I'm kind of getting on a bit of a soapbox. And I hope I answered the question to some degree.
Senator Clarkson, did you have a follow-up?
Yeah, I have a bit of a follow-up because I had someone speak to, so I'd just like to have you clarify that. Dorothy, it's my understanding that the VA has been practicing this expansion of practice, of scope of practice, for quite a long time. You've said, I think, 20 years. So it has been approved. There's had the federal scrutiny on these expansions of scope of practice has been considerable, one assumes, for the VAs around the country to allow these this expanded scope of practice. Can you just speak to that? I mean, there's a federal scrutiny on this. That have green lighted them, and the VA currently in White River is practicing this expanded scope of practice. Is that correct?
Correct.
Yeah.
So, sure. Sorry.
No, for a long time, right?
Yep. So, the VA is just like any other hospital. If you have to, when you apply for hospital privileges, you have to demonstrate that you have the education and the training when you apply for hospital privileges. And so there's a whole committee of people at the hospital that says, oh, okay, this person has the training, they've done this number of procedures. We're gonna, and when you ask for those procedures, you have to be, somebody has to observe that you've actually competent in these procedures. So that's been in place for a very, very long time. You do have to have licensure in the VA, and because it's a federal, because it's a federal agency, the way that I was able to, and the way most other VA docs are able to practice full scope of practice, is because they have licenses in multiple states. So for many, many years, I held a Tennessee license and a New Hampshire license. And I will tell you very funnily, well, it's funny to me that despite practicing in the Vermont borders for 22 years, I never, ever bothered to get a Vermont license because the scope just did not match my education.
So
I like Vermont.
What I would suggest as we go forward is that I think one question that has come up is that the bill be structured in such a way that there are specific procedures that are allowed and specific procedures or areas that are not allowed. Am I right? Is that kind of where Lauren took us, that was, so what I would like us to do is to, in addition to whatever other testimony you were going to give, and I think that we have heard from some of you before, but let's focus on those. If there already is a third-party accreditor, there is a national exam that includes all three areas, and you must pass all three in order to be licensed or to practice, to get your. So can we spend a little time also looking at the idea of having a list of procedures that are allowed and a list that are not allowed? Does that make sense, committee? Because I think we
Sure.
could, I don't want us to just spin our wheels here. I want us to actually see if we can get someplace.
Yep.
Does that make sense to you?
Yes.
Senator Clarkson?
Yeah, yes, I mean, I think I would take my cue from the optometrist if that works. I mean, I have a pretty clear understanding of the 3 areas they want to expand their scope of practice in, those 3 areas, and that they're like maybe up to 10 procedures within each of those areas that I think are most common. And but there may be many more. So I don't know if it's, absolutely. Yeah, sure.
Well, that's what I'm asking them to comment on,
Yeah.
is that a reasonable approach to have kind of 2 things here, combining the first bill and the second bill, and having a list that where the procedures that are allowed and a list of procedures that aren't allowed.
Yeah,
Okay.
and
I think next on our list, we had Steve St. Marie. Yes, Dean, did you? I want to give people a chance to testify who have not, but
You won't be surprised to hear me say that I like the bill the way it's written, and I think it perfectly encompasses the procedures that are and are not allowed. I just want to point out that we have either submitted, Heather's either sent to your committee or it is coming. I'm not quite sure which. Dr. Costello sent a 2-page letter to you folks following up on some of the questions that he heard that committee
Mhm.
members had. And so what he said specific to this question is, regarding the political opposition's insistence that specific procedures and CPT codes be individually listed, this is simply not practical. No matter how straightforward the procedure, surgery cannot be approached, nor is it taught, in a cookbook fashion where every procedure follows a rigid step-by-step recipe that never varies. The current CPT coding system does not and cannot cover every possible procedure or variation thereof. It is not unusual to find ourselves in situations where our billing experts tell us no specific code directly reflects the procedure performed. Hours are often spent with third-party payers attempting to resolve these matters. The qualified healthcare practitioner, an OD, MD, DO, Doctor of Dentistry, or DPM, must have the ability to modify technique and adapt to the intangible nuances that each patient encounter presents. It would be impossible for me as an ophthalmologist to give you a list of every procedure or variation I perform or may need to perform in any given instance. Other states have adopted either whole classes of procedures permitted or more practically to remove competitive restrictions on training and the need to consistently revisit and amend scope of practice legislation. Entire classes of procedures are excluded. He's referring to the bill. That's all I wanted to say. But I will obviously work with the committee on this, but I think the exclusionary language is pretty expansive. It's pretty specific. I think it leaves these 3 small areas that we've talked about. And I would press to leave the bill as it is.
I hear you. I also know that,
I'd support that.
okay, we want to hear from others. And I do believe that when the bill was first introduced, it was not introduced this way. It was introduced with a list of things that could be done. And that was unacceptable. So then it was introduced this way. So and I believe it was introduced with the support of the optometrist at the time, and with a list of procedures that could be done. So I'm a little bit confused now about why that. Anyway, we'll go on.
That's it.
And that's something that we as a committee have to deal with, is because these are all policy decisions and we want something that might pass. So, Lauren?
I just wanted to say that the bill in 2019 did have specific procedures.
Right.
And that led to debate and many cafeteria table discussions, quite frankly, about what should happen. And the result was the report in Act 30. That was where we led. I don't think that the specific list of procedures ever was, fully debated as a bad solution to the problem. There was opposition and discussion around the bill on whole, but I don't know, you would need to speak with the ophthalmologist, but I don't think they objected to the specific list of procedures. I think they objected to the concept in totality, and that's what led to the report. I think the specific procedures, while I understand Dean's point, I think the specific procedures or groupings of procedures adds a lot more clarity to all, to the public, for the practitioner. And, I get a little nervous when I hear, you start a procedure and then it can morph into something else or changes. That certainly, makes me nervous as a regulator, because I need to know who's authorized to do which things. So
I think that what I'm going to suggest that we go to Steve St. Marie, is that, and that we, as we go through this, we think about the combination of those two approaches, because the OPR needs to have more clarity about what can be allowed, and there needs to be some clarity about what can't be allowed. So, Mr. St. Marie, or Doctor, if you would like to join us.
Thank you. Can you hear me fine?
Yes, thank you.
Okay. My name is Steve St. Marie. I'm an optometrist in St. Albans, Vermont. I've been in practice for 28 years. I primarily see patients from Franklin County and Grand Isle County. I also see patients from Chittenden County, Lamoille, Orleans, and Washington County, where I grew up. I'm one of two optometrists in my practice in St. Albans. The bill S158 is not optometry's first expansion bill in Vermont. We expanded our scope several times. I was involved in the glaucoma expansion bill. That last expansion was going on 20 years ago. Optometrists are licensed and regulated doctorate level providers. We play a role in providing balance in our little corner of the ever-changing healthcare system, a system that is supposed to progress with new information, continuous education, and technological advancements. While the healthcare system continuously evolves, it's important that it remain balanced like a three-legged stool based on cost, quality, and access. With that being said, it's widely accepted that our current healthcare system is untenable. There is and will continue to be a great overlap in the scope of practice between physician and non-physician groups. This is the norm between optometry and ophthalmology. It's with no wonder then that every attempt by optometry or any non-physician group to update their Practice Act is systematically contested by organized medicine. Organized medicine attempts to frame healthcare in a very exclusionary and self-serving way. The medical establishment is well versed in distorting the context of good legislation like S158. They're adept at instilling fear and creating confusion about the role and place of non-physician provider groups like optometry. The medical establishment simply needs to do nothing further than cast doubt to stifle competition and paralyze an already untenable healthcare system. It's not good for the nation. It's not good for Vermonters. I'm going to tell you a little bit about what's in it for Vermonters with our bill. Improved patient access to straightforward office-based surgical procedures by duly trained, licensed, regulated primary care doctors. All surgical procedures are serious. All surgical procedures entail risks. That being said, each surgery has a context. Each procedure allowed in the context of S158 is straightforward, painless to minimally painful, quick, typically lasting 1 to 5 minutes, and fully befitting of a capable optometrist in a primary eye care office setting. These straightforward procedures should not be subject to disproportionate barriers. First, I'll talk about wait times. Our bill stands to significantly reduce wait times for Vermonters who need straightforward necessary treatment. In December of 2019, Lauren Hibbert, she had requested information that we could send into the OPR. She wanted testimonies from our patients. And I went right to work, and I devoted my staff to trying to mine patients. There was 3 procedures I was going to particularly target, patients who went through 3 different advanced procedures. And I had just enough to get through the first surgery. It was the SLT surgery. That's a 2.5-minute office-based procedure to treat glaucoma. I was able to mine 19 of my own patients in an 8.5-month time period. The SLT being a very safe and straightforward 2 to 2.5-minute laser procedure, it helps reduce or eliminate the need of eye drops to treat glaucoma. Here's what my particular data showed regarding access. There was a 5-week average wait time to obtain the first consultation, a consultation which my numbers will indicate are redundant. The average wait time from the date of referral to the date of the first treatment was 7 weeks. That's almost 2 months. If licensed, it would have taken us optometry 2 weeks or less to accommodate these patients in need. The average wait time from the date of referral to the date of treatment for the second eye was 3.5 months. These wait times are actual and significant. Our bill will eliminate the initial 5-week wait right off the top, as the consultation will be eliminated altogether. In turn, our bill will reduce or eliminate the need for many Vermonters to fill or refill their glaucoma drops while awaiting their SLT treatment. While some glaucoma drops are generic and relatively less expensive, some are not. Some of these patients are on multiple drops. In any event, the significance of cost and/or opportunity to save money will vary from patient to patient. But make no mistake, cost is never paltry to Vermonters in financial hardship and/or in medical debt. Wait times to treatment are significant for Vermonters who are non-compliant with their glaucoma drops as well. Studies show visual field defects are worse for patients with poor adherence to glaucoma drop treatment over a 3-month span. Our bill serves to improve patient outcomes. Wait times to treatment are also significant for Vermonters who are mentally or physically unable to install glaucoma drops on their own. Our bill supports more timely treatment for these folks. The numbers I compiled illustrate SLT consultations are redundant. Of the 19 patients I referred, 18 underwent the 2-minute procedure. The one who didn't undergo SLT was a patient who was not compliant with his drops, and ultimately he wasn't deemed to have enough pigment in this treatment zone to be deemed an ideal candidate. So for what that means is the more pigment in the treatment zone, the more typically effective the laser procedure is. This gentleman just didn't have it, but he was non-compliant on drops, and I wanted to make sure that we give him every opportunity to keep the pressures down. Anyway, my track record on the referrals to those who actually got the procedure was excellent. Our bill, the context of our bill, also addresses other straightforward office-based laser procedures such as YAG capsulotomy and laser peripheral iridotomy. YAG capsulotomy is a painless procedure that takes about a minute to perform in the office. 20% of patients having had cataract surgery will ultimately need this procedure. It's where we clean up this little film that grows on the back of a lens implant following cataract surgery. Because it involves 20% of patients who are post-operative with cataract surgery, it constitutes a lot of referrals back to the ophthalmologist that could have otherwise been treated more timely by optometrists. YAG capsulotomy provides relief for patients who are struggling visually with activities of everyday living, such as reading and driving. The timely return to activities such as daily living is self-explanatory. YAG capsulotomy can be performed same day if and when the situation or provider's schedule allows. The other laser procedure, laser peripheral iridotomy, LPI, is used to prevent the risk of an impending attack of an acute form of blinding glaucoma. It's another quick, safe, and straightforward procedure. Costs. Vermonters stand to benefit with costs as well. Going back to the 18 patients I referenced earlier who underwent the SLT procedure, 70% were on a fixed income. Our bill eliminates the cost of consultations, redundant examinations by secondary care level providers. As stated earlier, our bill reduces or eliminates the need for Vermonters to purchase glaucoma drops while awaiting SLT treatment. Our bill reduces or eliminates the need for some Vermonters to take time off from work. Many of these Vermonters are already in financial hardship and or in debt. Our bill reduces the cost of travel to and from doctors' offices for many patients, sometimes indirectly too, as some patients rely on their friends or family to leave work to bring them to their appointments. Our bill reduces exposure of many Vermonters to facility fees from current and future ambulatory care centers. Our bill reduces exposure of many Vermonters to facility fees from current and future in-state and out-of-state hospital outpatient departments, such as Dartmouth-Hitchcock. At last count, back in 2019, 14 Vermont optometrists on the eastern side of the state have referred Vermonters to Dartmouth-Hitchcock for these straightforward office-based procedures addressed in S158. The OPR did not consider how many Vermonters have been subject to facility fees over any time period. Regarding those Vermonters that would otherwise have been referred to Dartmouth-Hitchcock, our bill stands to keep healthcare dollars in Vermont. I think you'll have access to a list of cost comparisons. I believe you have access to that. Going back to cost, unnecessary or redundant medical costs are never paltry to Vermont living on a fixed income or already in debt. What is the effect of all this inefficiency? What effect is it having on our healthcare premiums? Passage of S158 will make Vermont a more attractive option for the recruitment of new optometrists to the state. Vermont is on the fringe of the country. St. Albans, I'm 14 miles from the border. We have cold winters. That's hard to get around. There are several optometric practices currently in the state right now trying to recruit doctors, including mine. In trying to add a third doctor to my practice, I sent job postings to 12 optometry schools, and to date, I've not heard from any students from any of the schools. Understaffed offices adds to longer patient wait times. Large job candidate pools give practices like mine more opportunity to vie for the best and brightest upcomers in our profession, and Vermonters would benefit from this. Lastly, Vermonters place a very high value on their choice of qualified provider. The fear, uncertainty, and doubt that organized medicine uses to paralyze legislation allowing for competition in the healthcare system raises costs, creates access barriers, and subverts patient choice of providers. Vermonters will get the best out of a system where both physician and non-physician groups are able to engage advancements in knowledge, education, and technology. Optometrists cannot do this without legislative updates. I ask that you support our bill. Thank you very much.
Thank you. I am going to jump next to Dr. Wait a minute, I figured it out here. Cisneski? Is that, did I do an anywhere near good job?
Close enough.
Okay, and I do want to remind us that we have half an hour left and we have 5 people left to testify, and then we need to have some time for committee discussion. So because at 3:15 we have another matter to take up, and we all need to have just a short break. So we have actually 35 minutes left. I'm just reminding.
I will not take up any more of the time than necessary.
Thank you.
So to the members of this committee, thank you for having me here today. I am Dr. Mitchell Stasinski, and I'm currently a resident in the optometry clinic at the White River Junction VA Hospital. Almost 2 weeks ago, I discovered that one of my students, Lubin, was scheduled to testify before your committee, and with his help, I was able to locate and watch the live stream in between patients. While I was very proud of optometry's representation during the meeting, I was disheartened and frustrated by many of the things that I heard. I am by no means an expert witness, but what I heard, combined with my experiences thus far in optometry, caused me to reach out to Dr. Barcelo with a request to present for you today. I am not native to the area. I grew up in Illinois, went to optometry school at Ohio State, and was fortunate enough to rotate through the White River Junction VA as a student. Having graduated optometry and successfully achieved licensure in Vermont, I consider myself lucky to be a resident at the VA that I rotated through as a student, while my wife actively assists those with Medicare at the Grafton County Senior Citizens Council in Lebanon, New Hampshire. Regarding the testimony that I watched, I wanted to emphasize that not only have I had every bit of training that was mentioned by those supporting this bill, but I have, along with the other 2 residents here at the hospital, already taken the 32-hour quote-unquote refresher course that was a point of contention during the previous meeting. Quite frankly, the material presented in that course was not new information to me. An ophthalmologist on the opposition mentioned that they could not count the hours that go into training for a surgical procedure, and to put it plainly, neither can we. The clinical and academic training received during optometry school in anatomy and physiology, particularly numerous classes and labs spent learning about and practicing with the surgical equipment involved in the procedures allowed by Bill S-158, as well as numerous years and thousands of hours spent training with the instruments, has already prepared us for these procedures. This bill allows 3 groups of minor procedures: using a laser to treat the tissues in the front of the eye, using injections in the superficial tissue of the eye and surrounding tissue, and removal of benign lesions like skin tags. Allowed procedures would only take a matter of minutes, and many are similar to what we perform already. If you already have a house, it's a simpler matter to build an addition or add on a room. For example, if I can use a syringe to dig a piece of embedded metal out of an eye while accounting for patient movement and preventing a perforated globe, I'm certainly more than capable of injecting the shallow tissues of the eye. Please do not let the opposing testimony distract you from the fact that we already have the training and use a majority of it daily. I know that the committee is faced between 2 sides entrenched in their own stances. Please understand that I have the ability and, at this moment, plan to take my training to one of the states mentioned in the previous meeting and practice at the highest level of my already achieved education. Additionally, it seems that by year's end, both Colorado and Washington will be added to the list of states that will allow full scope given their positive state regulatory reports mentioned in your committee. This will result in just shy of 20% of states allowing optometrists to practice to our training. The language you have before you seems to follow the language that is already passed statutorily in those other states, and if it has been working in those other states for years, it stands to reason that similar logic would apply here. If there really was any danger to the public, the bill would have been repealed in the other states when the harm was shown, especially given how hard our opposition has fought. The truth is, there's no change in outcomes. I would be more than happy to talk with you further on this issue, as until just under a couple weeks ago, I was unaware that this was even going on. However, as a recent graduate with all of the aforementioned training, I'm frustrated with my inability to help my patients even in the simplest of surgical situations. Thank you for your time and consideration. And also, I would like to say that I misspoke a little bit earlier. Instead of saying a syringe to dig a piece of embedded metal out of the eye, I meant to say a syringe needle, so I apologize for missing that word.
Thank you. And before we go any farther, I'm going to say that I just got a message that said my internet's connection was unstable. So if I get booted off, Senator Polina, you'll just take over. Okay. So any questions? or comments? Okay, I'm going to jump to Lisa Farrell. Fennel, I'm sorry. Lisa, are you there?
Senator White, I believe both
Oh,
of the
there she
Arbo,
is.
I believe both the Arbo Coat people were just here in case there were questions. I don't think
Yes,
they
I'm-
have direct comments.
Oh,
I'm here. I don't have anything additional to say, but yes, if anybody has questions, we're happy to answer them.
okay. And Sierra Powell, we also heard you're here for the same reason, to answer questions. I think
Yes.
okay, great, thank you.
You're
So
welcome.
I guess I calculated then in saying that we had 5 people to testify and 30 minutes. So I think we'll go to next on my list. I have Dr. Jeff Young. Where are you? There you are. Okay, so take it away, doctor.
Hi, my name is Jeffrey Young. I appreciate this opportunity to address this committee. I recognize the members of the committee and the members of the optometry community and ophthalmology community participating in this meeting and virtually watching the proceedings. So I'm a comprehensive ophthalmologist. I practice right here in Central Vermont. And I've done so for the past 8.5 years. I regularly perform all these laser procedures and minor procedures that they are requesting in this bill. I have a good relationship with my local optometry colleagues, and we share many patients. And I'm testifying here on behalf of my patients and the patients in this area, and in fact, all of Vermont. The concerns that I mentioned have been mentioned here by several, so I won't belabor them by giving extended testimony, but I do want to emphasize that as mentioned by Lauren Hibbert, this bill truly is expansive in the surgical authority that it would provide, where it lists these 17 procedure areas that are prohibited. It leaves open a wide range of procedures, thousands of procedures that could potentially be included. And so I think that's something certainly to consider with the language of the bill, allowing for an unknown number of procedures and unforeseen effects. As you all know, Vermont is unique. It's what drew me here to practice. It's not Oklahoma, it's not Kentucky or Massachusetts or New Hampshire. It's different. Vermont, the Vermont Office of Professional Regulation in their study took into account Vermont's unique healthcare landscape, and they found no need for the expanded procedures and no cost savings associated with this. And so I think that speaks for itself. The concern here, though, that makes me most uncomfortable, which I think is a little bit unclear in what's been said so far, is the deficiency in the training to perform these procedures. As you've heard several times about this 32-hour requirement that's mentioned in the bill, this is wholly inadequate to learn these procedures, even including and accounting for the training received in optometry school. I've thought a lot about training in general. In the past several months, my daughter is learning to drive. She's required to do 40 hours of driving with a licensed adult by her side in the car, in addition to taking didactic driver's education classes and passing a driving test, which is takes place in real world driving conditions and not in an empty parking lot. There's only so much you can learn from lectures and labs and books and videos. Even wet labs do not provide the same type of training that someone would need. The most important procedural training occurs not in a classroom or lecture hall or even a laboratory, but with real patients in a supervised training environment. A lot has been said about this procedural training, including the didactic training and laboratory training that occurs in optometric education. And as the OPR report concluded this training is uneven. It's important to note that there are only a handful of optometry schools, including in other states' reports, that allow their optometry trainees to perform supervised laser procedures in real patients. This makes a small fraction of those graduating from these schools, gives them the training that may be required to perform these procedures. This leaves the majority of optometry candidates with incomplete procedural training. And a weekend course will not supplement this because it does not provide the opportunity to perform supervised procedures on live patients. As any professional will tell you, training matters. And when dealing with the delicate tissues of the eye, as you know, they are very delicate. They have the consistency of wet tissue paper, and in many cases are less than a 1/10,000th of an inch thick. So there's not room for error. The hours that I and all ophthalmologists have invested in residency training, working with skilled surgeons performing these procedures with careful supervision, make the procedures safer and protect patients. The training available, as I mentioned, does not contain this component. I came to Vermont directly after finishing my ophthalmology residency at the Mayo Clinic in Rochester, Minnesota. Upon graduation from that program, I had already performed hundreds of procedures on real patients with careful supervision. In order to graduate, I had to meet the minimum Acgme, or Accreditation Council for Graduate Medical Education standards, which required certain numbers of each procedure. There were also very specific supervision requirements for each procedure to be supervised and vetted by a skilled and licensed ophthalmologist. Even for procedures that are considered simple, lasting only minutes, the supervision was still required. In my final year of training, I had the opportunity to spend time in Ghana in West Africa, learning global ophthalmology. At that point, I had already completed hundreds of cataract surgeries. And prior to my trip, I became certified as a Global Impact Fellow. I studied the various aspects of this manual cataract procedure that is performed in Ghana. I watched numerous videos. I even practiced on cadaver eyes in a wet lab. But I quickly learned when I arrived in Ghana, the value of proper clinical supervision as I attempted to perform my first manual small incision cataract surgery. During that first surgical case in Ghana, I was proctored by a very experienced and patient local surgeon. He performed thousands of these surgeries every year and could complete a case in less than 10 minutes. He helped me through that first slow case. The instruments were the same. The procedure was exactly as I had seen it in the lab, but it was very different on a real patient. He didn't just watch one case and then send me off to go and do surgery on patients. That would be unethical. He continued throughout that day, and even though it meant fewer cases that he was able to perform, he observed and critiqued each step until I was able to perform this procedure smoothly. We operated together on several more occasions, and the training continued until he was confident that I had mastered this procedure. As an ophthalmic surgeon and advocate for my patients, I ask that you not allow this legislation to proceed. We must protect patient safety and ensure the highest standard for surgery in Vermont. We all will likely end up on the other side of a laser, a needle, or a scalpel someday. And I know we all want the highest training and quality for the person on the other end. Thank you.
Thank you. Are there any questions? I do have one that my understanding, and I might have been wrong here, but my understanding was that the optometrists also have a residency program. And we just heard from a couple different people in the residency programs and supervising the residency programs. So I'm a little confused as to why the residency program that they have isn't
residencies, yeah, residencies involve different things, and I can't speak exactly to their residencies, but I know that ophthalmology is required to do a residency. That's the only way you can become an ophthalmologist, is by completing a residency, where for an optometrist, it's not required to complete a residency. People do that, but it's not required. And residencies does not necessarily mean that you're qualified to perform procedures. There are residencies for optometry in low vision, for example, which would involve no procedures, or other areas that involve no procedures. So a residency itself does not mean, for optometry, does not mean procedures. A residency for ophthalmology means procedures. That's what it is.
Okay, thank you. Other committee members, do you have any questions?
I don't really have a question. I just have a sort of a comment. I'm still I still don't feel like I adequately understand the educational process. I just want to put that on the table.
Madam Chair, I think Dr. Dorothy may have a response. I mean, we've just been hearing about residents in optometry situation. So I'm a little baffled by this notion that they aren't clinical and requiring all the things Dr. Young is saying there.
I think can I just maybe jump to Senator Polina's question about the education? There's 4 years of undergraduate education that includes all the pre-med kinds of courses that everybody who goes into medicine takes. Then there's 4 years of optometry school. And then on top of that, there's a residency or specialization, I would assume, programs, just like if you want to be an OB nurse instead of just an RN. But there are the 4 years of undergraduate that has all the pre-med courses, and then 4 years of optometry school.
But, well, this is more of a dialogue between us, which we could put off to later, actually.
Okay.
But I have the same question about the working on real people, real human beings, as opposed to, stand-ins.
Yeah.
But that's more of our discussion. It's just a
Okay.
comment.
So I'm going to, Dean, you're on the list next, but I see that Dr. Hitchmuth had a response to that. Do you want to take it, Dean, or?
I'll let Dr. Hitchmoth respond, and then I'll say whatever she doesn't say, and then do my part.
Okay, thank you. Thank you, Dr. Young.
Yeah, and I don't want to disrespect Senator Polina's comment that he wants to discuss that as a committee. So I will answer if he would like me to.
Sure, no, sure. You make your comments.
Yeah, so a couple things. And I agree with Dr. Young on pretty much everything that he said, that people should not be doing procedures on patients if they haven't had the practice on live people. That is a requirement in optometry for people who wish to perform those procedures. Our residencies are structured different than medicine. There's no doubt about that. Largely because we're not asking in this bill, and haven't asked in most of the other bills in all the other states that have passed this legislation, for example, to do cataract surgery. That's a much more invasive, requires a lot more practice, has other risks associated with it that just simply have no application in this particular bill. So one, yes, we do this on live people under supervision, many procedures, both before graduation and after graduation. We have more concentration in eyes before the end of our 8 years, whereas ophthalmology has more concentration after their 8 years. So it's just a rearranging and a combining that's different. It's not that it doesn't occur. Did I learn how to do cataract surgery? No. If I wanted to be a cataract surgeon, I would have taken a completely different track after pre-med, and that would have been appropriate. And I would say that's true for some of the more invasive hospital-based procedures, or even some outpatient surgery procedures. So I totally agree with Dr. Young that for certain types of procedures, this is absolutely true. And that's not what the bill is asking for.
Thank you.
You're welcome.
Yes, Dr. Young.
I just, the bill, the way it's written, does not indicate a training, this training requirement. So I know that, that's something they've been saying, but the training requirement in the bill talks about a 32-hour course, and it says, didactic and wet lab training. It doesn't talk about training with actual patients, residency training, anything like that. So I think that's something that, the bill is deficient.
I'm going to jump to Dean and then Dr. Hitchmuth, but I believe that that's already addressed in the underlying statutes for optometrists, that we don't, this isn't the entire statute that would relate to optometrists. There is already a whole section of law that relates there, and all of that is in that section of law that talks about the education and the training they have to be an optometrist. So this is not, we're not trying to reinvent what's already in statute, is my understanding. So, Dean?
Sure. Just a couple of comments. Last week, we had testimony against this bill where we talked about doing intravitreal injections and complications from those intravitreal injections causing problems. And this week, we've talked about cataract surgery as a complicated procedure that requires a lot of expertise and training. And I'd like to make very clear to the committee that we're not asking for either of those two things. Dr. Young referenced the Acgme minimums for procedures, and I have them up here on the screen behind me. And so, unlike cataract surgery, which requires a minimum completion of 86 procedures, the procedures that we're asking for require between 3 and 5. And if you do it in one eye, you get to count 1. And then if you move over to the other eye, you get to count the other. We're not asking for big surgical procedures here. And I guess I just like to make that really clear. The other thing I just want to say, Dorothy already said this, but optometry's 4 years are pretty organ specific. And when you take out the time frame that you have to put into going into your subspecialty, whether that's being a cataract surgeon or doing pediatric muscle surgery or doing retina, it's no wonder that they've got an extra year or two of training in there. But again, we're not asking for that. Let me pull up my last comments here. I know that this committee is looking at this, and they're looking for spaces to find some truth between two groups. The first thing that I would ask you to think about is the track record. So some people in this committee have been here long enough to have gone through more than one of these scope expansions. And I want to remind you that when we were going through glaucoma, I was in high school, but Tim Johnson, who some of you know, told me that ophthalmology said we're going to kill patients with timolol, that there was going to be this huge morbidity and mortality moment where we were going to have patients who went blind and died. And that just hasn't happened. Colin Benjamin, who was Lauren's predecessor, when we got this started, he actually said to us, optometry's track record with scope expansion is part of the reason that we have allowed other groups that are in our licensure to expand their scope, because we looked at optometry and it's gone well. We have a stellar record when it comes to scope expansion and safety. I want to, as the second point out that Dr. Costello, who testified last week and who has left a written leave behind that I'd ask each of you to read, because I think it really addresses some of the points this committee is worried about, is the only person who this committee has heard from who has gone through both educational tracks. He is both an ophthalmologist and an optometrist, and he educates optometry students, and he is giving you 2 thumbs up. If you're looking from somebody who is able to straddle both sides of the fence and tell you how it is, that's your guy. Number 3, we haven't talked a lot about it, but I think it's really important. Dr. Hitchmoth mentioned briefly last time about liability insurance and how liability insurance is distributed for optometrists across states relative to their advanced surgical endorsement or not having one, and there's no difference. So you have a third party that is looking solely at risk and determining from that risk that the premiums for a surgical versus a non-surgical optometrists are very similar. There is some differences from state to state, and that tends to have to do with the state law and the risk involved within that state law. Vermont tends to be a little tough insurance-wise relative to some other states. Last time this committee asked about exact numbers from other states for who is doing these procedures. And in the end, we weren't able to get exact numbers on short notice from every state. But I do have 3 letters that demonstrate we have thousands of optometrists across the United States who are performing these procedures and tens of thousands of performed procedures. This is not in its infancy. It may be its infancy here in the Northeast, but this is not in its infancy here. And those procedures are a standard to look at and to derive some comfort when it comes to allowing optometrists to perform these procedures. I want to also, in that same space, remind you that this 32-hour course came out of Oklahoma. It's written into the 7 other states, and it is not meant to be the comprehensive education that would allow the surgical procedures to happen. It is meant to take people like me who haven't been able to practice to my full scope since I practiced or graduated in 2009, to brush up, to review, to get some hands-on time to go through this and get it done. I also want to remind the committee members that this statute has a number of required bumpers or protections or barriers, including eliminating major portions of the eye from any optometric intervention, including a definition of what malpractice is, which states it is not having the education, training, or ability to do a procedure that you undertake. My last point is the federal government, in its report by the U.S. Department of Health and Human Resources, entitled Reforming America's Healthcare System Through Choice and Competition, has weighed in on this. And they recommend that optometry as a profession expand its scope, to expand access, to expand competition. And I'll also remind you within the same breath, the 2 reports that just came out from Washington and Colorado from their equivalent of OPR that both recommend scope expansion for optometry, in spite of the fact that our own state did not, due to what we've already discussed. There are only 3 areas that we're asking for: lasers for the anterior segment, removal of non-cancerous minor lesions like skin tags, and the ability to perform shallow injections in and around the eye. That's all I have to say today, and I certainly appreciate your support. Oh, one last thing, Senator White. I did not mean to imply that I would not defer to the committee for how they would like the bill to go. I was just stating an opinion for where I hope it will go. Thank you.
No, I understand that. Thank you. Senator Collmore?
Thank you, Madam Chair. So Dean, I did read the Washington report, and correct me if I'm wrong, but I think in that there was a recommendation that some of the procedures be enumerated.
That is true. And if that's the way this committee would like to have that happen, as I said, I would defer. My preference, when you port licenses between states, It is simpler if the language between states is similar. And the other 7 states that already have this basically all run off the same model language. The only amendment that we really made to this was to add the requirement of the 32-hour course for everybody, as opposed to saying everybody before a certain point had to have it and everybody after didn't. And we really did that at Lauren's recommendation.
Thank you.
So committee, I guess where we are is at the point for further discussion to look at what it would look like. And I don't know what at all what Lauren's time availability is here, but what it would look like is if we had, I guess more detail is what Lauren was asking for, or more information about what was allowed and what wasn't allowed. And so I would ask you to work together to come up with some language that maybe we can all agree on. Senator Clarkson?
Yeah, and as you look at that together, I'd also ask that maybe we consider tracking some of these procedures and having a report back and see how we're doing in 2 years. I mean, it strikes me that that people's discomfort would be, it would be great to see how we're doing. And you could identify specific procedures if you wanted, or and track them and see how it's going.
We could do that. I don't think we did anything like that when we did the glaucoma or the oral prescriptions.
Or the dilating drugs.
But there was that there was a I mean, there is a complaint that isn't the right word, but there is a procedure that people can go to at the Secretary of State's office for those. And if there are no complaints, I mean, that's the way I would do it. I guess I wouldn't ask for any more reports or tracking, or they already have so much to do. Although we know that Lauren is always willing to do whatever we ask her to do. So
I do my best, Madam Chair.
Does that make sense, committee, to look at how we would refine the language around what is and what isn't allowed, so that there's more, so that we can come to some consensus?
Yes.
I'm agnostic. I actually easy either way. There's some attractiveness about having similar language as other states, and I think that I feel comfortable with either way. If they can come to agreement, fine.
I just want to make it clear for the Secretary of State's office to administer, because I think that one of the things she said was that from their perspective, it would be easier if there were actual procedures identified here, so that they didn't have to decide if a procedure fell within a certain area. When there is, did I understand you? Is that the way
you summarized my testimony very well? And yes, that is my ask. And I would recommend that this committee look at the language in the 2019 bill and use that list, because that was very well debated between the optometrists and the ophthalmologists. I don't think there's going to be consensus between the two groups on, these are the ones that they agree upon. Although, you could ask them to go try and figure that out some more. But I don't think that's going to happen. So I would use the list from the 2019 bill as the draft list of procedures.
Yes.
Can you just, I sort of like the grouping of these 3 areas, and then the procedures within those, so that we can support both the areas that we're allowing scope of practice and the specific procedures maybe within those. But
I would ask this OPR and the optometries to work together to to come up with that list. If it's using the list that was in there in 2019, and I know there's not going to be consensus between the optometrist and the ophthalmologist, because I believe that any expansion is going to be opposed, not exposed, opposed. And so if you could work together, and if that's the list that makes the most sense, and you also asked for some kind of a, I don't want to call it no-go, but a
cataract surgery
yeah,
is one
yeah.
that is a no-go, and I think everybody agrees on that. So,
Yeah, so
But that's already in the bill.
But that's in, I was gonna say, that's
right. I just don't want it to be removed from the bill is my request.
that's what I'm saying. I'm saying the combination of doing it in both ways, the list and the prohibited areas.
Yes. So,
yes.
To be clear, do you want the office to engage with the ophthalmologists as well to get their perspective on the language? Because they may have suggestions on the language as well. I don't think it's fair to say that they'll completely oppose everything.
You are right. That was unfair of me. I just made a list of, while we were listening, I just made a list of, and this has nothing to do with optometrists and ophthalmologists, but of all the opposition that's been put forth every time we want to increase a scope of practice. So it had nothing to do with optometrists and ophthalmologists. So yes, I think that you should also work with them.
Okay. I do think the Medical Society has really made a diligent effort to support scope expansion when they feel confident that they can, and they have done that with pharmacy, just so that there have been instances where they have supported scope expansion. So I always like to have the door open and try and engage with as many people as possible.
And you're much more gracious than I am, so thank you.
So Senator White, we would be happy to work with OPR on that and get it done.
All right, and I'm going to suggest that we have now 3 weeks left before crossover. So we have to have this done in 3 weeks or it won't go anywhere. So I'm going to suggest is coming in perhaps next Friday. Does that give enough time? That gives a little over a week.
I don't think it will take that long to get it done. That may be a scheduling thing on your end, but I think it won't take very long to put that together.
Lauren? Okay. All right. Thank you, everybody. And we appreciate all the testimony and the ability to listen to each other. I think that, and you will, so we'll have the three groups, the optometrist, the ophthalmologist, and OPR working together to come up with hopefully a draft that will be acceptable and that we can use. And I will schedule it for next Friday.
Okay.
Okay, great. Thank you.
Thank you.
Thanks.
So committee, we're going to take a 7.5 minute break and come back. We have the Brattleboro charter change